Good morning. Thank you to SAGES for the opportunity to present my work here today. We have no disclosures to present that are relevant to the work that we'll be talking about. So I'll be talking briefly about the role of the robotic platform in revisional weight loss surgery specifically. Currently, the robot has been successfully used for all commonly performed bariatric procedures, including sleeve gastrectomy, Roux-en-Y gastric bypass, and duodenal switch. When considering patients who are undergoing their first bariatric procedure, the robot has been associated with shorter learning curves for the surgeon, equal or fewer complications for the patient, and although this is not universally reported, some newer series are showing that the robot can achieve shorter operative times. However, there's limited data that's available regarding the use of the robot in revisional weight loss surgery. It's important to consider this cohort of patients separately because, as we've been talking about throughout this morning, revisional weight loss surgery is technically challenging and often has a higher rate of complications. In the laparoscopic literature, many series have reported a complication rate as high as 30% for revisions. So we sought in our institution to compare our cohort of patients undergoing revisional weight loss surgery via either a laparoscopic approach or a robotic approach. Our institution is a tertiary care center and a bariatric center of quality. All patients at the time of their operation are prospectively entered into a database. We use this database to perform a retrospective review over the years of 2007 to 2016. We included adult patients who had failed an index procedure, an index bariatric procedure specifically, and were now presenting for revision. We included only patients undergoing revision by laparoscopic or robotic approach, so we did exclude a couple of open cases. We also excluded anyone who was undergoing a planned two-stage procedure, and we did not consider removal alone of an adjustable gastric band to be a revision. There are a couple of differences in technique to highlight between the robot and laparoscopy. Generally speaking, for the sleeve gastrectomy, either revisionally or as a primary procedure, at our institution we use linear staplers to create the sleeve over a 40-French bougie. Laparoscopically, the staple line is buttressed with omentum using interrupted vicryl sutures, as you can see on the picture to the right. Robotically, because of the increased degrees of freedom of the instruments, the entire staple line is able to be oversewn, and we use a 3-ovulok suture, and that's to help ensure hemostasis postoperatively. When considering the Roux-en-Y gastric bypass, the main difference in technique comes with creation of the gastrojejunectomy. Laparoscopically, we use an EEA stapler, which requires blind passage of an anvil through the oropharynx and esophagus. Robotically, we're able to perform the anastomosis completely transabdominally using either a linear stapler or hand sewing. So our hypothesis in this study was that revisional bariatric procedures could safely be performed using a robotic platform in our institution. Our cohort is as follows. It comprised 84 patients. 66 of these patients underwent laparoscopic revisional surgery and 18 underwent robotic revisional surgery. The patients were well matched with regards to demographics and baseline comorbidities. The one exception to this and the only significant difference was that the robotic group had an increased number of Black and Hispanic patients, and this is thought to be due to the surgeon practice patterns. So this was a complex cohort of patients. 44% had undergone at least 2 prior bariatric procedures, and over half were revisions after an index procedure other than adjustable gastric band. I don't show the exact numbers here, but in each type of revision, there were equal numbers between the laparoscopic and robotic groups. To the left, you can see the breakdown of what these revisions were. Just under 50% were conversions from a band to either a sleeve or a bypass. 20% were from a sleeve to a bypass. 15% were revision of a bypass, and so this was things like reshaping the pouch or revising the JJ. 10% were conversion from a vertical band gastroplasty to a bypass, and then the remaining 7 patients were converted to less common procedures like a mini gastric bypass or a single anastomosis duodenal switch. The patients were further characterized into 4 main groups based on the reason why they presented for weight loss, presented for revision. Just over half of them presented because they hadn't lost as much weight as they wanted or as was medically indicated. The remaining patients were broken into 3 groups approximately evenly. The first group was anatomic complications, and for this we considered things like stricture, ulceration, and a couple instances fistulas. The second group was reflux, and then the remaining group was patients that had refractory pain with eating or otherwise PO intolerance that was not due to an identifiable reason. So we did see some interesting patterns when we looked at why patients were being revised by the procedure that they had initially had. These differences were statistically significant. And what we found was that patients who had initially undergone lap band placement or vertical band were most likely to be revised for insufficient weight loss. Patients who had undergone a sleeve gastrectomy initially, not unsurprisingly, were most likely to be revised for reflux, although a significant number of proportion of them also were not losing enough weight. And then the bypass patients were most likely to be revised for an anatomic complication. When comparing the laparoscopic group and the robotic group head-to-head, we saw no differences in the intraoperative or immediate post-operative outcomes, and these were the primary outcomes that we were looking at. Specifically, there was no difference in operative time. There were no conversions to open or intraoperative complications in the robotic group. Post-operatively, our rate of complications was about 20% overall in each group. Most of these were minor and were things like surgical site infections and urinary complications. In terms of major complications, and these are patients that had to return to the OR, go to the ICU, or have an endoscopic intervention, the rate was 6% in each group. There were no leaks in the robotic group and only one stricture. Length of stay was shorter in the robotic group, although this was not statistically significant, and there were no differences in 90-day readmissions. On follow-up, we evaluated the patients to see whether they got better from their presenting symptoms. All of the patients in this study had at least some improvement in symptoms on follow-up, and this was based on the patient self-reporting symptoms and resolution of medication use. 92% of these patients had complete resolution of their symptoms on follow-up, but this resolution rate was not different based on the surgical approach. There are some notable limitations in this study. Most significantly, the robotic sample size was obviously much smaller than the laparoscopic sample size. Because of this, we didn't have the numbers to compare patients within groups, so we weren't able to compare, for instance, the patients undergoing sleeve to bypass lap versus robotic, so that's a real limitation. The other main limitation was that our follow-up was quite limited. It was less than 6 months in the robotic group and just over a year in the laparoscopic group. So for this reason, I don't report on any long-term weight loss data or anything like that. And this was, of course, a retrospective review. However, in conclusion, we found that the robotic platform can be safely used to perform revisional bariatric surgery, even in a complex group of patients. And when compared to laparoscopy, we saw no increase in operative time or in complications. This is our group. Thank you.